You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to ATS Breathe Easy with me, your host, Patti Tripathi. Each Tuesday of every month, the ATS will welcome guests who will share the latest news in pulmonary critical care and sleep medicine. Joining me for today's conversation on vaccines and vaccine compliance in adults are Dr. Rob Stansbury and Dr. Dona Upson. Dr. Stansbury is the West Virginia University Vaccine Project Lead. He's also professor in the Division of Pulmonary Critical Care and Sleep Medicine at West Virginia University. And Dr. Upson is professor of medicine, pulmonary critical care and sleep at the University of New Mexico. According to my sources, Dr. Upson, you have a reputation in the Fellows Clinic for making sure all patients get appropriate vaccinations. Welcome to you both. As a pulmonologist, you know that our patients are at higher risk for severe disease from respiratory infections. And what concerns you the most, Dr. Upson?
Thank you. I'll clarify that, make sure that all the patients who want to get their vaccines can get them. I'm concerned that a lot of people, especially those with chronic respiratory illness, are going to get very sick in the next few weeks. Many will be hospitalized, and some will die prematurely. Our hospitals are already filling up due to increases in respiratory infection rates. The peak is expected to come in early February. For those who survive, especially those with respiratory disease, they often do not recover fully and end up worse than they were before they got sick. They're not just sick for a week or two. They may never get back to their baseline. A lot of that suffering is preventable with vaccination. They may still get a respiratory infection, but they won't get as sick as if they weren't vaccinated.
And Dr. Stansbury, you know that your pulmonary patients tend to be more open to vaccines than many patients, but some may still have concerns about side effects. How should clinicians address these concerns, and what are some of the risks, and how do they compare to all the benefits?
Thank you for having me, and that's a really great question. I think physicians do a good job of discussing the benefits with the patients, but I think what part of the conversation is sometimes missed is just having that open discussion about what are the possible side effects and addressing those concerns with patients. Probably the most common side effect is soreness, swelling, or irritation at the injection site. But other side effects that can occur include headache, fever, nausea, and muscle aches, which, depending on the vaccine, can occur up to 15 to 20% of people who are vaccinated. These symptoms typically decrease over 3 days or so. There are very rare but potentially devastating side effects that some studies have suggested at least an association with. One of those is Guillain-Barré syndrome, which is essentially an autoimmune reaction to the vaccine where you can develop a paralysis. Now, when this has been looked at, it's fewer than 1 or 2 cases per 1 million people who are vaccinated. So we're talking about very low numbers here. In the case of COVID vaccine, there has been studies suggesting increased incidence in myocarditis or pericarditis, which is swelling of the heart or swelling of the sac that contains the heart, and inflammation that occurs. This has been seen mostly in adolescent men. When you look at males 12 to 15, there's 70 cases per million doses that have been reported. And when you look at males 18 to 24, it drops to 50 cases per million doses that have been reported. Again, these are very, very small numbers, but certainly, consequential side effects. That being said, these side effects are very rare. And the reason the Advisory Committee on Immunization Practices and the CDC continue to recommend these vaccinations is due to the really positive impact it has in preventing illness in patients, particularly those with lung disease, preventing hospitalization, and as Donna referenced, preventing premature death. These potential benefits really outweigh these very small risk of these devastating consequences.
ATS has been fortunate to have been awarded CDC CMSS grant to use the QI approach to study what works to improve vaccination rates. What are some key takeaways you've learned in your health system that others can apply that you say are very unique?
And I alluded to this a little bit, but I think it is worth mentioning utilizing this formalized QI approach to understand systematic and health system immunization practices has been very helpful as we implement study ways to improve vaccination rates within our pulmonary subspecialty clinics. This approach really allows us to measure changes over time and more broadly share what we learn across with stakeholders across the country. I think a key takeaway that really separates the ATS approach and this QI initiative is the application of implementation science methodologies. As we develop and deploy these different interventions, we don't just stop there and say, well, this worked or this didn't work. We really try and tailor and adapt things we develop to meet the needs of that local clinic and make sure it's as successful as possible. And I think this will be important for providers and health systems as data that comes out from this initiative, and they're considering what they can do locally. Just to illustrate this point, the vanguard health systems for the ATS Vaccine Initiative are West Virginia University, WVU Medicine, the University of Arizona, Banner Health, and the University of California, San Francisco Health Network. So obviously these serve very different populations, and all the health systems have very unique idiosyncrasies that can make delivery of interventions a challenge. So, for instance, if you're implementing an intervention to improve vaccination access in San Francisco, this may be very effective given there's a dense population, there's good availability of public transit. Whereas if I was trying to do the same thing in West Virginia, this may be much less practical or not even feasible, given how sparse our population is and how geographically isolated our communities are. So, as these things come out, you really have to consider, what is practical for my institution? What are things that we think are going to have really good success, and how can we tailor those to meet the unique needs of our population, of our health system, of our providers? One of our interventions that we developed at West Virginia University locally was an EHR dot freeze intervention that was really targeted at reminding clinicians to have that discussion with patients. And I think we'll discuss this a little bit later, but when we did our clinical workflow diagram, we really tried to highlight what are barriers to patients having vaccines available to them who do want to be vaccinated. And one of the things that kind of our team highlighted was just having the time in that discussion with the provider. So we developed a intervention to place into our pulmonary note templates that really just serve as a reminder to providers to have that discussion with patients and make sure that patients who want to have a vaccine and want to have that discussion had every opportunity to do so.
And Dr. Upson, patients need to be empowered to make decisions about vaccination and other medical decisions. What do you find motivates your patients to get vaccinated?
I think the main motivation is the desire to stay as healthy as possible, to be as independent as possible. Most are already limited by their respiratory status, and they don't want to get any worse. They also want to protect their families and their communities.
Thank you. And Dr. Stansbury, you've been studying on how to improve vaccination rates in your clinic. What have you found to be the most effective intervention that have really changed the data. And you spoke a little bit about it earlier.
Yes, and this is kind of timely because we just got a sneak peek of our data that we've been submitting to CMSS and CDC. And I think our dot phrase intervention is actually going to be proven to be fairly effective. And, what was really interesting about, developing and adapting this was the whole process behind it. As I mentioned, we developed our clinical workflow and thought this might be a really important place to intervene, to improve that access and opportunity for patients to get a vaccine. And when we initially developed it and rolled it out, the uptake was actually pretty poor. And some of it was my fault. I said, these are busy clinicians. We have to make this as simple as possible. And, we can't have a lot of extra detail in here that's going to take up time when they're, trying to complete their clinic node. And so after, we kind of had that poor uptake, we did some interviews with providers and just kind of looked at the trends and who was using this dot phrase. And from that data and the feedback we got, providers really wanted more information. They wanted to really be able to document that interaction with the patient. They even asked if we could make a free text box so they could really capture what the patient was telling them, why they wanted a vaccine or why, they chose not to, get a relative vaccine. And after we made those changes, we saw a dramatic increase in the usage of the dot phrase. Now, really what we've been waiting on is looking at the data to see, great, the providers are using it. Now, what's that impact on, vaccinations? And as I said, at least from the preliminary look I got at our data, I think it's going to be pretty impressive.
Okay. Whoever wants to jump in, your patients are mostly in Appalachia, you said West Virginia, and Dr. Upson, yours are on the opposite side of the country in New Mexico. Is the approach different, or do you have other approaches for people of different cultures?
I don't know that I adapted to different cultures. I think in general, I treat my patients pretty much the same. They know that I care about them. And I'm more fortunate than some of my colleagues in the private sector in that I have a little bit more time with them. I generally have half an hour. So I wait until later in our discussions to bring up sensitive issues like smoking status or vaccination, maybe 15 minutes into the visit. And that gives them time to assess, if they don't already know me, whether or not they think I'm trustworthy. And it gives me a sense of, time to get a sense of their concerns. I never tell my patients what to do. I make recommendations. I discuss the benefits and possible side effects. As Rob mentioned, I think that's really important, that we're honest with the patients and that they know that we're telling them the truth. I ask them if they're planning to get any of the vaccines for which they're due. And if they are, we can usually give it right there in the clinic. So that gets rid of a major barrier that some clinics have. If they're not willing to get it, I asked for the reasons that they're hesitant, acknowledge their concerns, and I ask if it's okay to talk about them. I try not to be judgmental, and I let them know that it's always their decision. And it's my job to help them make an informed decision. And sometimes I tell them how many vaccinations I've gotten and that I recommend them to my parents who are in their 90s.
Anything else to add?
I think to Dona's point, obviously all patients should be treated equally. I think what really stands out about this QI approach we're using, though, is there are intricacies to different health systems, providers, clinic workflows. But some of the things we're developing are going to have to be adapted to those environments. So I think that's going to be a key takeaway from this initiative, is really we're already starting to see set sort of common themes that may help with, improving vaccine uptake, kind of across the different health systems. But I think how you implement that at the different health systems is going to be different.
I'd like to thank you both for sharing your expertise with us today. And to our listeners, thank you for joining us for today's ATS Breathe Easy episode. Please subscribe and share this episode with your colleagues and anyone else who needs to hear this discussion. For more on vaccines, check out the ATS Vaccine Resource Center for vetted and trusted information for clinicians as well as patients. We'll drop the link in our show notes. You can also download the Centers for Disease Control's mobile app on your smartphone. And I'm Patti Tripathi. We'll see you next time.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.